And now it's my pleasure to welcome Dr. Lee, who's my colleague at the Brigham. She's our pharmacist, our transplant pharmacist, and very knowledgeable. And I'm looking forward to learn from her talk.
All right. Thank you so much for the opportunity today to present transplant immunosuppression. My name is Caitlin Lay. I'm currently one of the transplant pharmacists practicing at Brigham and Women's Hospital, so very excited to be having this talk with you guys this morning. I have no financial interests or relationships to disclose. For today's objectives, we'll be talking about some of the core kidney transplant immunosuppressant agents, as well as some key relevant drug interactions associated with such medications. When I think about the goals of immunosuppression, really, I envision it almost like a balancing act where we know that too little or too much medication can have its respective consequences. The overall goal is really to individualize these medication regimens in order to improve patient and graft survival. So today we'll be primarily talking about induction and maintenance therapies and jumping right into induction immunosuppression. Induction immunosuppression is really defined by our intense therapies utilized at time of transplant in order to decrease the rates of acute rejection. And looking at SRTR data, for adult kidney transplant recipients within the United States, at least 90% or so are receiving some form of induction at time of transplant. When we break down the types of induction therapy, at least 70% of these adult kidney transplant recipients are receiving some form of a T-cell depleting agent. So some examples of those agents can include rabbit antithymocyte globulin or alemtuzumab. And then around 20% of these patients are receiving something like basiliximab, which is an interleukin-2 receptor antibody. For choices of induction immunosuppression, a different way of breaking them down would be dividing them based off of if they're polyclonal versus monoclonal antibodies. And for the purposes of today's talk, we'll primarily be only discussing rabbit antithymocyte globulin and basiliximab, which is more readily available across U.S. transplant centers. Jumping right into rabbit antithymocyte globulin, its trade name is thymoglobulin, and it's abbreviated as RATG. Thymoglobulins represent polyclonal antibodies that are created through immunizing animals, such as rabbits, with human lymphocyte in order to create antibodies against human T cells. And they're going to be directed against various different T cell markers, and the primary modality for immunosuppression would be through T cell depletion via complement-dependent lysis, activation, and apoptosis. And there's several other mechanisms involved as well. But this is a potent medication, and the duration of activity can last several months, which means that cellular reconstitution can also require several months. Thymoglobulin is FDA approved for prevention and treatment of acute rejection for kidney transplant recipients, and we typically reserve this agent for higher immunologic risk patients, patients at higher risk for rejection. Thymoglobulin does allow us the privilege of being able to slowly get that calcineurin inhibitor on board over the following days after transplant, as well as it permits us the opportunity to explore steroid withdrawal protocols for our patients. In terms of dosing thymoglobulin, the dosing can really vary depending on your local institution's protocols, so definitely refer to that. In terms of administration, before considering thymoglobulin for your patient, as a reminder, this is a medication derived from the serum of rabbits, and so something that you would want to screen for when choosing thymoglobulin for your patient is, do they have a history of rabbit allergy? Because this medication could have concerns or contraindications. Regardless, though, if you do end up choosing thymoglobulin for your patient, you do want to pre-medicate your patients with a combination of steroids, antihistamine, and acetaminophen in order to minimize the risk of infusion-related reactions. For adverse reactions, monitoring-wise, each day that a patient is getting dosed with thymoglobulin, the CBC should be monitored closely because decreases in white blood cell count or platelets may warrant adjustments in thymoglobulin dosages. there is the risk of infusion-associated reactions. If it's mild, such as with hypotension, mild hypotension, that can often be managed by slowing down the rate of infusion. However, if it's more severe, as a cytokine release syndrome type of picture, that might be a reason to perhaps consider stopping the infusion altogether, stabilizing the patient, and then reassessing appropriate induction accordingly thereafter. There are some other side effects to be aware of, such as serum sickness, which can present, it's rare, but it can present at least 2 weeks after the initial thymoglobulin exposure. And then long-term, we monitor for the risk of malignancy and infection as we would with any other immunosuppressant. Basiliximab is a less potent immunosuppressant agent. It's a chimeric monoclonal antibody that competitively inhibits the activation of lymphocytes by interleukin-2, and this will prevent further expansion of T cells. In comparison to thymoglobulin, basiliximab does not cause cell lysis, and its duration of activity is much shorter in that it can only saturate the interleukin-2 receptor for only up to 45 days or so after receiving this medication. For palliative therapy, we typically reserve basiliximab for lower immunologic risk patients as it is a less potent agent. And so think about perhaps the patients who might be considered HLA identical. We also reserve basiliximab perhaps for patients who might be older in age with more comorbidities or significant immunosuppression history. And of course, we reserve basiliximab as an option for patients who might not be appropriate to receive a medication like thymoglobulin for induction. The dosing of basiliximab is more straightforward in that it's just 20 milligrams on post-op day 0 and post-op day 4, and pre-medication of this medication is often not considered to be necessary because it does not cause that cell lysis cytokine release effect that thymo would cause. So this is going to bring us to our first case question, which describes patient KT. He's a 75-year-old male weighing around 67 kilograms, and he has a past medical history significant for CKD stage 4. He has acquired solitary kidney due to renal cell carcinoma, and his status post-right native nephrectomy from the year prior. And he's scheduled now for a preemptive living kidney transplant from his brother. Some other key information, CPRA score is 0%. He's got negative B and T cell cross matches. There's no DSA, and it's a 6 out of 12 antigen mismatch. So what type of induction should KT receive? A, basiliximab, B, thymoglobulin, C, a combination of both basiliximab and thymoglobulin, or D, none at all. So I'll give you a few moments to answer. And great, I'm seeing some answers, and a vast majority is choosing A, which is basiliximab, and that's great. I would also recommend basiliximab induction, primarily driven by his age. This is an older gentleman, and he also has a past medical history of malignancy. So moving right along to maintenance immunosuppression. So for maintenance immunosuppression, I describe this to be less potent agents in comparison to the induction immunosuppression, and they're typically reserved to be used long-term following kidney transplant. The goal really is to minimize the risk of acute and chronic rejection, but these medications do have a number of toxicities, so it is really important to manage these medications with those in mind. For SRTR data, at least 70% of adult kidney transplant recipients are receiving some combination of tacrolimus, mycophenolate, and corticosteroids at time of discharge. But we'll talk about all of these different agents throughout today's discussion. Looking at the timeline of immunosuppression, it's important to recognize that there's a 70-plus year history of kidney transplant immunosuppression, but a lot of our backbone agents that we utilize today really came about after the 1990s. And so we'll intermittently reference this timeline throughout this discussion. The three-signal model that was published in New England Journal of Medicine by Halloran and his colleagues in 2004 is a really great way to describe some of the immunosuppression signal targets. So it breaks down with the antigen presenting cell toward the top and then the T lymphocyte toward the bottom, and describes three different signals. So signal 1 describes the CD3 complex, where an antigen on the surface of dendritic cells triggers the T cells with T cell receptors. Signal 2 describes co-stimulation, where CD80 and 86 on the surface of dendritic cells engage CD28 on T cells. And then signal 3 talks about the target of rapamycin that ultimately will result in cellular proliferation. Before we begin talking about the maintenance immunosuppression options, I think it's important to be familiarized with some basic principles, which are pharmacokinetics, pharmacodynamics, and therapeutic drug monitoring. So pharmacokinetics describes what the body does to a drug. How does it absorb it, distribute, metabolize, and excrete? Pharmacodynamics, on the flip side, describes what drug does to the body. And then these principles are brought together with therapeutic drug monitoring, where we can utilize objective drug levels in order to assess a patient's safety and efficacy on a certain medication. Drug interactions is a very important thing to keep in mind for kidney transplant recipients, because oftentimes they may be on medications such as calcineurin inhibitors or mTOR inhibitors. And these classes of agents are what we call CYP3A4 substrates, meaning that if you introduce a CYP3A4 inhibitor or an inducer alongside that substrate, you may have inadvertent increases or decreases of drug concentration levels, and that might subject your patient to over or under immunosuppression and potentially side effects as well. And so if you have a patient on a calcineurin inhibitor or mTOR inhibitor, it's really critical to be aware of what some of these inhibitors or inducers are, such as protease inhibitors, azoles, macrolides, diltiazem, verapamil, and then also select antiepileptics, rifampin, and certain supplements. We also do worry about pharmacodynamic interactions with some of our medications, where we know that these medications can potentially put patients at risk for kidney injury. And so we want to really be careful about introducing other potential risks for injuries, such as NSAIDs or aminoglycosides. And then we know that our transplant immunosuppression is also myelosuppressive. And so we want to make sure we're monitoring our complete blood cell counts very closely, especially given that a lot of our patients will be on medications that can synergistically increase those risks. Ultimately, for therapeutic drug monitoring, there's a myriad of different influential factors. So we talked a little bit about drug interactions, but in addition to that, there's a lot of intra-patient factors that we need to be cognizant about, such as protein and erythrocyte binding, renal hepatic dysfunction, how is the patient's gut function, are there specific pharmacogenomic factors involved, and so on and so forth. Now, we'll jump right into calcineurin inhibitors, which are oftentimes recognized as our backbone of maintenance immunosuppression. And so the agents we'll talk about today include tacrolimus and cyclosporine. So calcineurin inhibitors are relevant roughly around the signal 1 portion of that 3-signal model that we discussed. Calcineurin is a critical enzyme involved in the dephosphorylation of nuclear factor of activated T cells. And that dephosphorylation will end up creating interleukin-2 proliferation later on down the road. That would be one of the downstream effects. And in order to combat that, cyclosporine and tacrolimus are able to inhibit calcineurin, which prevents those downstream effects of interleukin-2 proliferation down the road. Traditionally, our older calcineurin inhibitor agent was cyclosporine, which was more prevalent used in around the 1980s, but in the 1990s, tacrolimus began to gain more favoritism because it was recognized that acute rejection rates are reduced with tacrolimus-based immunosuppressive therapies. There are some differences with regards to adverse effect profile with the calcineurin inhibitors, but there are some similarities as well. And this might influence your choice of immunosuppression for your transplant recipient. For example, tacrolimus may have higher association with neurotoxicity, which can manifest as headaches or tremors. There can be risk for electrolyte abnormalities such as high potassium, low phosphorus, low magnesium levels. And then on the flip side, cyclosporine may be associated with more nephrotoxicity, more hypertension, more hyperlipidemia. So we'll go and first talk about the immediate release tacrolimus product, which can be based off of a weight-based dosing strategy. However, you might feel comfortable approaching dosing in some other method. But ultimately, for most patients, they end up being maintained on 2 divided doses given every 12 hours. So a BID schedule for tacrolimus. And this is oftentimes, it will be titrated to an institution-specified trough goal. For immediate release tacrolimus formulations, for the enteral formulations, we have capsules, granules used to make oral suspension, and then compounded oral suspension as well, which would only be available through compounding pharmacies. There is also an intravenous solution formulation available of tacrolimus, but use is often discouraged given that there can be a lot of risk for harm if the dosing conversion is done inappropriately, if this medication is administered inappropriately. And also it contains castor oil, which can present as a increased risk for hypersensitivity reaction. So typically, if at all possible, usually the recommendation would be to elect an immediate release tacrolimus formulation that would be given enterally. And this would be given typically twice a day, 12 hours apart. And we advise our patient to take this medication either consistently with food or without food in order to yield stable tacrolimus trough monitoring. It's important to recognize that outside of the immediate release tacrolimus formulation, which would be Prograf, there's also extended release formulations that do exist, such as Astigraf and Novartis. And so these formulations, really critical to recognize that they are not one-to-one bioequivalent. There are some differences with regards to how they are produced. And so bioavailability will be quite different between the formulations. But regardless, these medications are absorbed throughout the GI tract, and we advise our patients to be consistent, either taking it with food or without food. Tacrolimus, in terms of distribution, it is highly protein and erythrocyte bound, and it's also going to be affected by the small intestine P-glycoprotein pump. Metabolism of tacrolimus is important to recognize that it is extensively through the CYP3A4 and 3A5 systems. And so this brings us back to our CYP3A4 inducers and inhibitors. There's going to be a lot of drug interactions involved to be very cautious and cognizant about. Pharmacogenomics with tacrolimus is also very interesting because we do know that CYP3A5 polymorphisms can influence your patient's tacrolimus dose requirement and how they metabolize this medication. It's recognized that patients who are considered expressors, so if they're homozygous for the CYP3A5 star 1 allele, they might actually require a much higher dose of tacrolimus to maintain similar exposures as patients who are considered non-expressors and have non-functional alleles. Elimination of tacrolimus can be very variable depending on what type of formulation that the patient is receiving, but also keep in mind that there's also disease concerns, such as if a patient has hepatic dysfunction, they might end up having tacrolimus levels linger a bit longer. In general, for a stable patient at steady state for tacrolimus, you can extrapolate, use their dose requirements utilizing linear dose proportion pharmacokinetics. So you can use that calculation to estimate what dose adjustment you need to achieve a certain desired target trough level. As mentioned previously, the tacrolimus formulations are not one-to-one bioequivalent. When you transition patients between different formulations from the immediate release to the different extended release formulations, you're going to need to make dose adjustments. And so this actually brings us to a really interesting pharmacokinetic curve image to describe some of those differences. So in green, you will see Prograf, the immediate release product. In blue, you will see Invarsis. And in yellow, you will see Advigraf, also known as Astigraf. So if you're converting somebody from immediate release tacrolimus, also known as Prograf, over to Invarsis, which is in blue, you'll actually need to do a 30% dose reduction to account for some of those pharmacokinetic differences. Where I think this pharmacokinetic curve is also very interesting is because sometimes patients on tacrolimus may experience peak-related toxicities, and that can oftentimes manifest as tremors. And so if you review the green curve, which represents Prograf, that peak effect at around 2 hours of that concentration can oftentimes be associated with the tremors. And so if you convert a patient over to Invarsis, oftentimes, because Invarsis achieves a lower peak level at around 4 to 6 hours following the dose, patients might actually see improvement in some of those neurotoxic side effects. Now, this brings us to our next case question, which talks again about patient KT. And he's now post-op day 14 after his kidney transplant, stably maintained on tacrolimus 5 milligram twice a day, and his trough level is around 9.2, and his goal range is right within the 8 to 10 mark. But he's now sharing that his hands are newly tremulous in the mornings, and he reports that his friend actually also experienced the same thing after their kidney transplant, but somehow improved after switching to Invarsis. So KT also wants to try that change. Now, what would be the most appropriate conversion dose of Invarsis for KT? Is it A, Invarsis 5 milligram in the morning, B, Invarsis 7 milligram in the morning, C, Invarsis 10 milligram in the morning, or D, Invarsis 5 milligram twice a day? All right, so I'm seeing the vast majority of patients choose the correct answer, which would be B, Invarsis 7 milligrams once a day in the morning, and that accounts for that total daily dose reduction of around 30%. So wonderful. We will move onward to cyclosporine, which is our next calcineurin inhibitor agent, and this is a little bit of an older agent. There are two main formulations of cyclosporine to be aware of, the first of which is the non-modified version, Sandimmune, and its bioavailability is considered to be poor and variable. There's a modified version of cyclosporine called either Neoral or Gengraf, and these have improved bioavailability of up to 30%. Really important to recognize that these modified and non-modified formulations are not interchangeable and thus are not bioequivalent. Regardless of what formulation you elect for your patient, it should be either taken consistently with or without food. Cyclosporine, similar to tacrolimus, is highly protein-bound and extensively metabolized through CYP3A4, bringing us back to those inducers and inhibitor medications. Really important to be mindful of those relevant drug interactions there. For elimination, this medication typically is recognized to have a half-life of around 8 hours or so, and time to achieve steady state would be around 2 or more days. And this again highlights that the formulations are not bioequivalent. Sandimmune is the older formulation that's really fallen out of favor given its suboptimal pharmacokinetic profile. For most kidney transplant patients today, starting on cyclosporine, if they needed to be on cyclosporine, it's recommended to choose a modified cyclosporine formulation, either Neoral or Gengraf, in order to choose a medication with a better bioavailability and more consistent pharmacokinetic profile. In a perfect world, for medication monitoring, we would use area under the curve monitoring to best characterize what kind of medication exposure a patient is getting throughout the day. So it turns out that cyclosporine area under the curve measurement anywhere between 0 to 4 hours after they take the dose, that would be the time that reflects the max immunosuppressive effect of Neoral. But in reality, it's not feasible to necessarily sit there and have a patient monitor levels over a 4-hour period of time. And so investigators have identified that measurement of 2 hours after a patient takes a dose of cyclosporine would be a good correlation with that AUC over 4 hours. But we unfortunately cannot do that because there's a C2 monitoring, which would be 2 hours after a patient takes a dose of cyclosporine. It can be impractical because you really only have a plus or minus 15-minute window for capturing that respective drug level and interpreting it accordingly. So in terms of practicality, it's best to just use the C0, which is trough monitoring for monitoring cyclosporine efficacy and safety. So just summarizing calcineurin inhibitors a little bit here, therapeutic drug monitoring is very advantageous in order to try to characterize the safety and efficacy of these medications. A lot of programs have very different targets for medications such as tacrolimus and cyclosporine, so it's best to refer to those local institutional protocols for specific goals. But some general target trough ranges can be anywhere between 5 to 15 for tacrolimus or 100 to 300 for cyclosporine, depending on how far your patient is out from transplant and what kind of rejection risk they are at that moment in time. Therapeutic drug monitoring can be very advantageous to utilize if you're suspecting a medication toxicity or rejection, and you might want to implement this a little bit more frequently if you're frequently adjusting medication doses or adding or subtracting any potentially interacting medications. Along this whole process for therapeutic drug monitoring, though, really important to individualize your medication monitoring plan accordingly. Now, moving right along to antiproliferatives, which would oftentimes be coupled with calcineurin inhibitors for transplant immunosuppression, we have azathioprine and our mycophenolate products. So azathioprine and mycophenolate are ultimately going to interfere with purine synthesis in order to exert its immunosuppressive effects. We'll first talk about mycophenolate, which is the product more often chosen. So mycophenolate, there's two specific products to discuss. There's mycophenolate mofetil and mycophenolate sodium, and they do have some differences. The similarity is the active product would be mycophenolic acid, which exerts its immunosuppressive effect, but they are released at different portions of the GI system. These formulations are also not bioequivalent, so that is important to keep in mind if patients ever need to be transitioned between these different products. Mycophenolate mofetil is CellCept, which is the slightly older product, and this is rapidly absorbed within the hour in the stomach, versus mycophenolate sodium has delayed absorption that occurs within the small intestines. Regardless of formulation, when we educate our patients, we advise them to take it either consistently with or without food. And my personal preference would be recommending patients to take this medication with food because we will discuss that mycophenolate does have some effects on GI distress for certain patients. This medication is also highly protein bound, and it's metabolized by liver esterases into its metabolites. So mycophenolic acid is the active moiety that produces the immunosuppressive effect, and that's abbreviated as MPA. And then along the road, the liver will help transition it into MPAG through glucuronidation, and that's the inactive metabolite that ends up getting renally excreted later on down the road. There is a really interesting phenomenon from a pharmacokinetic standpoint with mycophenolate, which is enterohepatic recirculation, where the inactive MPAG product can actually be converted briefly back into active MPA to exert some further MPA concentration levels several hours after the initial dose exposure. And so kind of re-summarizing the mycophenolate pharmacokinetic profile, if you have a patient taking mycophenolate mofetil, that's going to be converted, that's going to be absorbed in the stomach, and mycophenolate mofetil will convert into active MPA. To exert the immunosuppressive effects. And in circulation, MPA will eventually turn into the inactive product MPAG, and that's the glucuronidated product, inactive product that ends up getting renally excreted. down the road. And then along the process, MPAG, while in circulation, also has the opportunity to reconvert back into active MPA within the blood. And how that looks is at around 7 to 8 hours, you can have that intrahepatic recirculation effect where you get a second bump in the MPA levels. So this represents a MPA AUC exposure over time. Mycophenolate mofetil and mycophenolate sodium, again, they are different products, so they are not one-to-one bioequivalent. You do need to make some dosing adjustments accordingly. So some suggested dosings for adults listed are there. Really important to note that mycophenolate sodium is only available as enteric-coated tablets, which means that if you have a patient that cannot tolerate taking whole pills at a moment in time, they may end up needing to be converted over to mycophenolate mofetil as the suspension or IV solution formulation. In terms of administration, I recommend patients to either take it with or without food. And for monitoring, we don't have routine drug monitoring established for mycophenolate because there is limited validation with some of the mycophenolate AUC and MPA measurement techniques, but they can potentially play a role if somebody is having medication-related toxicity or malabsorption or rejection concerns. In terms of adverse effects of mycophenolate, predominantly patients may complain about GI distress, whether that be nausea, vomiting, diarrhea, and we'll talk about some strategies for management in that setting. Other adverse effects would be effects on white blood cell count and hemoglobin hematocrit, so those numbers should all be routinely monitored. There are some select drug interactions to keep in mind with mycophenolate, which include antacids, bile acid sequestrants, proton pump inhibitors, and sevelamer. And so those additions of those medications would require careful consideration because they can potentially affect mycophenolate mofetil concentrations. Cyclosporine also has an interesting drug interaction with mycophenolate where it can actually interfere with that intrahepatic recirculation. And so you might not necessarily get that MPA bump that occurs at around 7 to 8 hours after the initial exposure to the mycophenolate product. So GI side effects typically are considered to be a large side effect for mycophenolate products, and that can manifest as nausea, vomiting, or diarrhea. And so there are some strategies for GI side effect management, which might include changing someone from mycophenolate mofetil, which is cell-sipped, over to mycophenolate sodium, Myfortic. You can also consider fractionating the dosing strategy. So some patients are able to tolerate this medication a little bit better if they take smaller doses, but more frequently throughout the day. However, that should be considered with caution because it may add some medication administration burden to the patients and risk some consequences with adherence. And then also there's a potential role for lowering the overall dose of mycophenolate, as well as if those measures fail, sometimes patients may need to be considered for alternate anti-rejection medications such as azathioprine. Really important for providers to recognize that mycophenolate does come with a REMS program specifically relating to its risk of teratogenicity, especially for females of childbearing potential. And so for any female of childbearing potential, they should have mycophenolate REMS patient prescriber education reviewed with them. And this includes reviewing the risk of miscarriage and birth defects associated with mycophenolate, but also reviewing acceptable birth control options. So the mycophenolate REMS program does have a lot of great resources on its website to review. So azathioprine is our next anti-rejection medication that is an anti-metabolite. And for this medication, it's oftentimes considered if a patient ends up having GI adverse effects with mycophenolate, or perhaps if you're taking care of a female who's planning for pregnancy later on down the road. And azathioprine does not have routine monitoring required, but it is beneficial to consider checking thiopurine methyltransferase activities at baseline, just because deficiency of this may actually predispose a patient to developing azathioprine adverse effects, such as myelosuppression. In terms of drug interaction potential, something really notable to keep in mind is azathioprine does have significant drug interaction considerations and concerns with xanthine oxidase inhibitors, which are a lot of our common gout treatments, such as allopurinol and febuxostat. I'll show you why that is here. And so azathioprine is a prodrug for the active metabolite 6-mercaptopurine, 6-MP. And 6-MP is what exerts its immunosuppressive effects, but it's also associated with toxic analogs that can increase the risk of a patient developing myelosuppression. And so if a patient is deficient in TPMT, that's where they can develop increased concentrations of 6-mercaptopurine. And on the flip side, if you have patients on xanthine oxidase inhibitors such as allopurinol and febuxostat, that's where they're not able to break down into the inactive metabolite product, and they can have azathioprine metabolite accumulation, subjecting them to myelosuppressive toxicities. Now moving on to our next group of medications, which are our mTOR inhibitors. These will include sirolimus and everolimus. So sirolimus and everolimus will target right at the cell cycle around the signal 3 section. And sirolimus and everolimus do have a lot of overlapping similarities with calcineurin inhibitors. In terms of absorption, we ask our patients to take it either consistently with or without food so we can achieve stable trough monitoring goals. We do know that similar to calcineurin inhibitors, sirolimus and everolimus are highly protein bound, and they're also both substrates of the P-glycoprotein system. In addition, CYP3A4 metabolism does play a big role for mTOR inhibitors. So again, that's where we need to be careful with our CYP3A4 inducers and inhibitor medications. A major difference of the sirolimus and everolimus medications is that they do have exceedingly long half-lives. So that is something important to take into consideration when you're starting this medication to get someone close to steady state. It may take several days, and also this medication, because it has a long half-life, it may take quite some time for these medications to be cleared from a system as well. There's a really interesting drug interaction to be really considerate of if ever starting a patient on an mTOR inhibitor. It so happens that cyclosporine, a calcineurin inhibitor that's commonly used, cyclosporine can actually cause significant increases in mTOR inhibitor exposure. That effect is not replicated with the different calcineurin inhibitor tacrolimus, but it's important to take into consideration that if you ever have a patient on cyclosporine and mTOR inhibitor combination, they're going to be at higher risk for developing toxicities. And the reasoning behind that is cyclosporine is a P-glycoprotein inhibitor, and these mTOR inhibitors are distributed through the P-glycoprotein system. So this is a drug interaction to be very aware of. mTOR inhibitors do have some drug or adverse reactions associated with them. And so impaired wound healing tends to be one that can be of concern, particularly if a patient may be undergoing an elective surgical procedure later on down the road. This is where if a patient is undergoing one of those procedures, it may be reasonable to consider holding the mTOR inhibitor in preparation for that respective procedure. There's also other adverse effects that are associated with mTOR inhibitors to be very mindful of, such as dermatologic side effects, pneumonitis, angioedema, effects on the CBC, increased cholesterol, proteinuria, as well as the risk of thrombosis. And there are a couple of black box warnings out there regarding the risk of thrombosis in allografts. Now, for corticosteroids, at high doses, doses of methylprednisolone and prednisone can actually induce T-cell apoptosis. But in the medical community, we do recognize that steroids do have their myriad of adverse effects, ranging from diabetes, hyperlipidemia to hypertension, and also effects on skeletal muscle system. And so a lot of our transplant patients, particularly kidney transplant recipients, already have a lot of these comorbidities. And so that's where we need to be very cautious with steroid exposure for the transplant recipients. And since around the 2010 era, there have been a lot of investigation regarding steroid withdrawal protocols. And so a lot of kidney transplant programs are actually interested in withdrawing steroids entirely from kidney transplant recipients after a certain number of days or weeks after transplant. And that can be successfully done with augmentation of maintenance immunosuppression as well as appropriate choice of induction immunosuppression. One of the newer agents available is a co-stimulation blockade agent, also known as belatacept. And belatacept targets right out signal 2. This medication is an IV medication that's approved for the prophylaxis of organ rejection among kidney transplant recipients. And ultimately, when patients end up getting loaded on this regimen, when they hit the maintenance immunosuppression regimen of belatacept, the maintenance phase, it's oftentimes only administered once every 4 weeks or so. Some advantages to belatacept would be that it can actually potentially have EGFR preservation benefits in comparison to calcineurin inhibitors, but it's oftentimes not considered to be a first-line option because there is association with increased risk of acute cellular rejection, especially when compared to calcineurin inhibitors. But it does have a place in therapy where we consider belatacept in patients who might have unduly calcineurin inhibitor toxicity, such as if they have significant neurotoxicity, renal toxicity, or even a unique scenario where they might have thrombotic microangiopathy from a calcineurin inhibitor. But really important to weigh risk and benefit of this medication, just because there is that increased risk of rejection that it may be associated as well. We also want to carefully consider this in our patients because this can only be used in patients who are Epstein-Barr virus seropositive. Patients who are naive for the Epstein-Barr virus can actually have increased risk of developing post-transplant lymphoproliferative disorder. There's also other considerations to keep in mind when initiating belatacept therapy, such as will they have access to an IV infusion unit? Will they have transportation? Or will they have insurance barriers? So on and so forth. But in summary, transplant immunosuppression safety and efficacy can be influenced by so many different variables. There's so many intra and inter-patient factors that can affect therapeutic drug monitoring for medications. And so medication monitoring does require a very, very high level of attention to detail, and it's going to be an ongoing balancing act of risk and benefits for immunosuppressive therapies, and always consider patient-specific factors when establishing those individualized goals. But the good thing is whenever able, we do have the opportunity to use therapeutic drug monitoring to help us achieve those goals. So thank you very much for listening to my talk, and I have some references here.
Great, thank you very much.